Hamilton and my student number is 3361804, and I've been chosen to look at competency 1, 3 and 5. Within my first competency of prevention of injuries within a sporting environment, I rated myself as a 3 as I had previously learned level 5 taping techniques within class. During this, I learned how to use zinc oxide tape as a preventative measure to tape the shoulder, elbow, wrist, knee and ankle. In this, I found the ankle the most challenging to remember, and I took an image to ensure that I remembered how to tape this. The ankle is most common for spraining, as there is multiple ligaments and tendons within the ankle to remember. This is the image that I took a picture of to remember. From this, my competency rating increased from a 3 to a 4 as I experienced turf toe within clinic at level 6. This was when an athlete came in and he was a rugby player and he wore boots a lot. From this, I didn't know anything, and my tutor recommended us looking in the sport and exercise medicine book within university. Within this book, I learnt what turf toe is, and it is caused by overextension at the hallux, which is the big toe. And we got taping techniques out of the book, and we also was shown how to conduct this by our tutor and was given the opportunity to do this ourselves. From this, my competency rating increased from a 4 to a 5, as also in clinic, me and my partner experienced a core stability exercise program with a patient who was suffering from external rotation problem at the shoulder. This was linked to his poor core stability, as he could have prevented this injury if his core was stronger and could withstand the pressures that swimming took him through in more detail. As after the session, we was told by our tutor to relook at this and create a program. This exercise program included the plank, mountain climbers, leg raises, side plank, flutter kicks, Russian twists, and repeated over a 6-week period, as we referred to the ACSM guidelines of building strength. From this, within my own time, I created a core exercise strengthening program. Within my large included, I referred to the Gibbs model of 1988, these prevention of injuries within a sporting and exercise environment. And throughout my experiences, I had covered taping in lesson, exercise programs, taping in clinic, and creating an exercise protocol. And this overall improved my score to a 5. Within level 6 clinic, I had to create a full exercise program for a patient who was suffering from core instability. Whilst gathering our patient notes, we gathered that the patient was a swimmer who had a very busy schedule. He was presenting rotator cuff stiffness along with bilateral back soreness. His training included a lack of S&C and a lot of pull sessions. From this, we gathered that he had a grade 1 rotator cuff tear, and our tutor gave suggestions of exercises to follow. I was also mentioning our patient had a lack of core strength due to the muscle slings in his body and bad posture. Whilst creating a plan, I felt elevated to put my creative skills to the test by adding isometric and dynamic exercises within my program. While I had assistance from the tutor, he was giving us recommendations for timings and repetitions. This increased my confidence of building an exercise protocol. Then I felt more confident in creating programs to make them specifically progressive whilst referring to the FIT principles. The best part of experiencing this was being able to have free reign of designing the protocol by adding my own thoughts and exercises into the program, Also experiencing what it's like to conduct correct exercises with a patient whilst promoting correct technique. So giving a proper correct technique of how to conduct the exercises so I can go away and do them properly. The negative to this was having only 15 minutes to create a protocol, and with the end protocol being more efficient, that we had to create in our own time. Also, the timing could have helped the situation and be less smooth as we had to create a protocol with limited time, but having both of mine and my partner's thoughts, it helped us as we had good communication with the patient of demonstration. The challenges that presented included our patient being worried that they'd forget the whole program. To prevent this stress, we gave them recommendations of writing the exercises in their phone so they could check them online. And to add further demonstration of our patient from suffering from another injury due to his core being weak. The Blazer 2019 research suggests that a lack of core instability can increase the chances of developing an overuse extremity injury by 24%. When an appropriate modality is implemented, risks of injury can be reduced and ultimately prevented. Walker B's research in Fit Principles opposed opinion around injury prevention. This research that the Fit Principles should slowly be introduced and controlled to become more effective, whereas when an athlete changes mentality to increase when sprinting, can increase the risk of injury. This research concludes that our exercises could have included more information of timings, intensity guidelines referring to RPE, and having more clear progressions whilst following Fit Principles carefully. In the future, I could research other protocols to make mine more effective, as mine didn't have much research to back it in preventing injuries. Overall, my competence within injury prevention is quite low as I haven't experienced much outside of the university. I am keen to learn more around pre-season planning and planning my own sessions to improve as a sports therapist. During my third competence of management, treatment and appropriate referral, I first rated myself as a 2. So I first started off with treatment, and that was massage treatment that I learned in level 5. For this, my first competency, I rated myself as a 2 due to me having a lack of experience, and I was currently being taught massage techniques within class. These included effleurage, petrissage and tapotement. During this, we also found trigger points in which my tutor recommended me to apply my bodyweight pressure directly over the top of these trigger points for 30 seconds to release myofascial tension. During this, my tutor mentioned that sometimes the knot is too stiff to be massaged out and recommended giving regular massages to future patients. This confused me as I felt like I had a duty to remove these at the point. Research suggests that applying pressure to a trigger point of the lats reduce the size of the sarcomere by adding that manual pressure can release and be effective for therapy. In the future, I will use trigger point release around myofascial sites to keep releasing these pressure points. During my time at the Leeds Rhinos, I had been taught how to pin and stretch and was taught additional techniques to release muscle and myofascial tension. I then increased from a 2 to a 5. This is due to me experiencing a concussion in level 6 clinic. Within my time at the clinic, we experienced a American football player that came in with a lack of cognitive function. He seemed fine originally, however, when conducting a SCAT-6 form, he then permitted that he had cognitive deficit. From this, we spoke to our tutor, and he explained that we should refer our patient to a walk-in clinic. So this is an example of a SCAT-6 that we were told to do within class. From this SCAT-6, we were told to conduct cognitive tests such as coordination, ocular motion, loss of range, tenderness, and memory and cognitive functions. From my level 5, I then increased to a level 6, as during my level 6 clinic, we had a patient with left anterior knee pain inferior to the patella. Throughout the subjective assessment, me and my partner picked up that our patient had Osgood-Schlatter disease as recommended by our tutor. From this, I had no previous knowledge of the disease or what it was about. From my research of Osgood-Schlatter disease, it is a condition that affects the anterior tibia and causes bony bump at the tibial tuberosity. This happens during the growth stages of being a child and causes a bony palpation and feel at the top of the knee. So from my research and from my knowledge of what Osgood-Schlatter looks like, I then had a look, and this shows the extensive growth of bony tissues on the end of the knee. This can cause pain and sometimes a dull ache to the patient. We then took the patient through a full joint clearance, and from this, she found it hard to resist against 90-degree flexion. From this, my tutor advised me to take the MCL and the ACL test. In this case, I applied medial and lateral pressure to either side, in which the patient still felt anterior pain when I applied lateral pressure. I advised my patient to come back to the clinic for a sports massage on their stiff leg, hamstring, and also prescribed some sit down and stand up exercises to build stability within the injured knee. In my Gibbs model large reflection, I referred to management, treatment, and appropriate referral. Throughout my experiences of managing and treating injuries and conditions at university and my external placement, I have experienced a lot of hands-on work with massaging patient, writing notes, recommending exercises and changes to lifestyle. My concussion and further referral on pin and stretching is forever growing and improving. During my time of treating the SCAT6 patient, I felt challenged due to my lack of experience and not knowing how to conduct a SCAT6 form properly. From this, we first started with a short list of words to test short-term memory. After completing the full assessment, I had some assistance from my tutor to sit our patient out for 4 weeks due to his symptoms scoring above a 14. They also recommended referring the patient to a walk-in clinic for further assessment. From this, I felt disappointed for my patient as they enjoyed doing sports in their leisure time and took this seriously. However, I understood the importance of resting and taking time away to recover. Academia et al. 2023 concussion guidelines state that any athlete with a suspected concussion should be removed from play, medically assessed and monitored for injury. They should not return to play until symptoms have gone. Manley 2017 research shows that sport-related concussions can improve long-term effects on American football players, whilst affecting their chances of developing neurological defects and depression within the long term. From this, I feel like it's safer to look after an athlete's long-term health by making short-term changes to injury and implementing long rest times. I will continue to follow this protocol in the future and can remind athletes of repercussions caused by concussion. Next time I treat a concussion, I can warn athletes of the dangers of concussion and give them clear advice from the British Journal Sports Medicine as to how long they need to sit out for. With this self-referral will increase my competence as I can improve factual recommendations within my practice. From this, I did my own research and I looked at the BJSM guidelines for the SCAT6 form and looked through it. And if there are any red flags that have occurred, then it is safer to sit the athlete out than. Overall, I can improve on my management, treatment, and appropriate referral as a sports therapist, and I can keep increasing my competence as I will see different injuries every day. Now I know the signs to appropriately refer a concussion. Throughout my fifth competence, education and professional practice, my competence rating first started as a 2. At the start of level 6, I rated myself as a 2. This was because I had completed my first aid at work certificate at level 5. This gave me an immediate knowledge of sudden events which lead to saving a life or protecting one. Then it increased from a 2 to a 4. This is due to me attending the Manchester United Sports Conference, in which there were 6 speakers from all different backgrounds, and they covered acute trauma, which included risks, prevention, and experiences ranging from cardiac arrest to head injuries. Discussions on the day covered trauma, head injuries, and how to approach and manage this fast and effective. Also, how MSK ultrasounds and injections can aid diagnostics and management. Also, the director of the ATMIF course spoke about the importance of improving modern day knowledge whilst implementing and updating professionals with new and more effective approaches. From this, my competency rating increased from a 4 to a 5 as I attended Jonathan Ball's meniscus tear Zoom call, which improved my knowledge on common injuries and complexities within the knee. This common associates with ACL, MCL, LCL, and all being strained through the damage of ligaments. From this, my knowledge on prehab and patient care before surgery is important, along with movement/exercise specific preparation. This also made me realise that the meniscus surgery is long and it has a long, challenging rehabilitation programme. Some of my meniscus tear notes are included here, and they include parts of the meniscus, talking about the purpose of the meniscus, which is to spread load and increase stability along the knee. Also, this is my certificate of when I attended the Man United press conference. I also attended an employability day and a mental health CPD. The employability day increased my knowledge of knowing what type of options I have once I graduated and the different routes that I could have took within hospitals, clinics, and sporting teams. Within the future CPD that I would like to complete, I would like to become self-employed within sports therapy. The additional skills that I will have to learn include cupping, shockwave therapy, and online webinars to increase my knowledge of treating injuries and conditions. I will have to regularly join webinars to constantly keep my practice skills up to date and effective. I can find these courses on the Society of Sports Therapy website, along with regular free CPD being available. So this is an example of the cupping therapy course that I'd like to complete, and these are held in different locations around the country. As I want to become self-employed within sports therapy, I will have to join forums, groups, and keep constantly updated with my research to ensure that my practice is reliable and effective. I have completed over 200 hours of placement, which included my time in the Leeds Beckett Clinic, also along with spending my time at the rugby club Leeds Rhinos, along with my CPD opportunities. One example of my placement hour log sheet is here.